even when that need is obvious. In particular, there's often a lack of equipment or processes to facilitate telehealth or point-of-care testing or use of artificial intelligence or similar. Concerningly, there can also be negative consequences for prisoners for seeking acute healthcare. I'm actually aware of prisoners having their privileges withdrawn if they are taken to hospital. So a quick run through of the legal and convention backgrounds. Australia is a signatory to, but has not enacted legislation incorporating a number of human rights conventions. Collectively, these state that prisoners should enjoy the same standard of healthcare that is available in the community. 3 Australian states have human rights legislation. All of them require that persons deprived of their liberty should be treated with humanity and respect. Courts have determined that protection of human dignity includes the provision of appropriate medical treatment. And prison authorities, which are defined as public authorities or entities under those acts, have obligations to comply with the acts. Obviously, there is correctional services legislation and policies. The Corrections Acts or their other state equivalents mainly go to the issue of access to healthcare. The actual processes underlying the hows and the whys of it are covered in non-legislative policies and guidelines. Some of these have stated quality frameworks, others don't. Others are in the form of service agreements, memorandums of understanding, or general guidelines. But the principles are around access, equity, high quality, and human-centred care. And our review found some problems with all of these issues. You may be aware of the National Healthcare Standards. These were developed in a collaboration between the Australian Government, states and territories, private sector providers, clinical experts, patients and carers. There are 8 main standards. Their aim is to protect the public from harm and to improve the quality of health service provision. They set out the level of care that consumers can expect from a health service. In hospital accreditations, healthcare standards are assessed against these standards. It is not clear to me how or if prison health services utilise or assessed against these standards. 4 of these standards have particular relevance to emergency health care. The recognition and responding to acute deterioration standard is basically about recognising high-risk symptoms or unstable vital signs such as abnormal blood pressure, pulse, temperature, respiratory rate, that's potentially indicative of serious illness, and having a structured process that escalates that person to the appropriate level of healthcare to their condition. In particular, escalates it to an emergency health response or to calling in a doctor or calling an ambulance. The comprehensive healthcare standard is largely about person-centred care and health maintenance, and basically goes to the management of chronic conditions and to patient preference in their healthcare. The communication for safety standard is about making sure that everybody with responsibility for a person's healthcare has the information that they need to protect the healthcare of that person and to act appropriately. In the case of prisons, that includes information sharing between prison officers and healthcare practitioners, so that both are on the same page when a person is being monitored for a potentially serious healthcare condition. The clinical governance standard is about the systems that maintain and improve quality and safety. I could probably talk about that all afternoon, but it basically covers things such as policies and procedures, measuring performance and quality improvement activities, risk management, incident review and management of complaints, quality of health records, provision of evidence-based medical care, and a safe environment for healthcare. I'm aware that a number of cases of prisoners, of deaths in prisoners, have been referred to civil litigation. Prisoners' authorities owe prisoners a duty of care that extends to the provision of their healthcare, and issues are usually about access to and quality of the healthcare provided. Obviously, individual practitioners also owe a duty of care to exercise reasonable care and skill. Adverse health events can lead to action in negligence, but the issues are complicated and best left to a lawyer to explain in detail. The number of actual cases of litigation resulting from healthcare in prisons is unknown. I was unable to locate any that are in the public space. Overall, we know that more than 98% of civil liability claims are settled on a confidential basis. So this is information that is almost impossible to obtain. So let me talk a little bit about our research. So with Veronica's death as a catalyst, an idea formed in my brain to see if we could identify through a search of coronial findings issues related to the provision of emergency healthcare in prisons in the last 10 years. Potentially preventable deaths are the tip of a healthcare iceberg. If we can identify those deaths and analyse them, we can probably identify issues that impact the quality and safety of healthcare in a much larger proportion of prisoners. Luckily, Jessica Wu took up the challenge of this project. We excluded deaths due to suicide, violence, or accident. And then we analysed those cases for their key themes. I'm going to provide you some examples of the cases. These are certainly not a comprehensive list, but they highlight the major issues that were found. Overall, the key issues were that prison authority policies and procedures could actually delay access to timely healthcare or compromise the quality of healthcare. Things like requiring a prison officer to go first when there was a call for help and then let the nurse know or not. Things like assessing a person through the trap door of a cell without actually taking any vital signs, those sort of things. There were operational and logistic factors, like who had the keys to the door and when and how quickly they could be obtained. There were clinical issues, which I'll discuss in a minute, but there are also stigmatic issues, including prison staff attitude and at times clinical staff attitude to prisoners who were requesting urgent healthcare assistance. A tendency to dismiss their concerns was something we found quite common. So let me give you a couple of examples. So one example of inadequate emergency care was a case of Nathan Reynolds in New South Wales. Nathan was a young person, relatively young man, who had a long history of asthma, and he died of acute severe asthma. The issues that we identified were that there was a requirement for a certain number of officers to be present to respond to a call for emergency assistance after lockdown time, that prison officers had to assess the situation themselves before calling a nurse or even calling an ambulance. There was a lack of urgency in the prison officer response to a call for emergency assistance. There was a delay in calling an ambulance. There was incorrect initial treatment. And there was also poor chronic treatment, which, if it had been better, might have avoided these events totally. Another example is the death of Damien Nobley, which occurred in Victoria. Damien died of what's acute epiglottitis, which is when a small structure at your back of the throat swells, usually due to infection, and blocks off your breathing passages, such that you suffocate. The issues we identified in that case were inadequate assessment through the trap in a cell door, failure of the nurse to measure vital signs, not paying enough attention to all of the evidence available. Damien's cellmate provided an excellent account of events and called for help multiple times on behalf of Damien, but was ignored largely. A failure to respond to multiple calls for help with a lack of escalation, not taking calls for help seriously, and delays to calling an ambulance. And then, as I've mentioned, the death of Veronica Nelson. Veronica had drug withdrawal, vomiting, and a condition called Wilkie syndrome, which has to do with the control of the blood chemicals when you're undernourished and vomiting. I'm not going to go into the details. It's a bit too much for non-clinical audience. But the issues we identified there were a one-size-fits-all drug withdrawal management program, an inadequate initial medical assessment, again, an inadequate nurse assessment through the trap in a cell door, that calls for help go to a prison officer who had to make a health assessment, even though they had no training or access to the health information. The fact that opening a cell door required the co-attendance of the supervisor, who might be at a distant part of the prison. A desensitization to patients' experienced drug withdrawal. Not taking calls for help seriously. A disconnect between justice staff and the service contracted to provide the healthcare, particularly around information sharing, and no escalation despite multiple calls for help and prison officer concern. There was just no pathways for that. As well as emergency healthcare, we looked for examples of inadequate access to healthcare for urgent conditions that are not necessarily an emergency, but could be fatal if not dealt with expeditiously. Two great examples of this are the cases of Craig Lingwood and John Lawrenson. Craig Lingwood had died of malignant melanoma. There was a delay in diagnosis. He saw the doctor in the prison several times about his condition, about a concerning mole. Eventually, the doctor in the prison made a referral to the local hospital for specialist services. There was no response to that referral, and the doctor failed to follow up on the referral. After the referral was acted on at the local hospital, there was a delay to surgery and treatment, by which stage the condition was not curable. John Lawrenson had died of a ruptured brain aneurysm, which is an abnormal outpouching on an artery in the brain that is weak and prone to burst, causing a fatal type of stroke. When he went into prison, it was known that he had the aneurysm and that he needed neurosurgical follow-up. But the doctor in the prison decided that it could wait till he was discharged from prison. Unfortunately, John died in the meantime. The escalation and access to medical staff issue went across all of the acute cases. There was a reliance on nursing assessment rather than assessment by a doctor, even when really serious symptoms such as I can't breathe were reported. And there was a failure of prison officers or nurses to act on calls for assistance in a timely and appropriate fashion. Listening to the audio recordings of Veronica Nelson calling for help and being told to be quiet, she was keeping everybody awake was totally harrowing to hear. I think some of the issues have got to do with how prisons see themselves. They don't see themselves really as health services, or don't seem to. I don't think they realise that they are the prisoners' health service and need to provide health care as core business. They seem to have suboptimal clinical governance processes for healthcare, and healthcare is sort of an add-on. And in particular, there seems to be a lack of integration between justice and health. Now, I know that in New South Wales and Queensland, there are memorandums in particular, there are memorandums of understanding between departments of health and justice. So these issues may not be as prevalent there, but it was certainly an issue that came up in a number of the cases that we analysed. So what can we do to improve emergency healthcare in prisons? Well, the first and probably the area with the biggest bang for buck and the quickest wins is improving clinical governance and organisational aspects such as policies and procedures. Similarly, there needs to be an attitudinal change, a cultural change. Those are not the topic of today's talk. I'm going to talk about the technological stuff which can support those other areas of improvement. So, how could technology be part of the solution? Well, if you think about a recent GP visit that you might have had, most GPs use structured electronic templates for their medical assessments and their notes. And when you see a GP for the first time, as I did recently, they ask you a whole lot of questions which go into that template, which are aimed to identify your chronic health issues, if you have any, and to trigger testing or follow-up or action plans for those conditions or for your general health based on your age group and risk. That technology is already available and there. It also includes the technology to have automated callbacks, to schedule automated appointments for regular follow-up reviews, as many of the ladies will know for their follow-up for their pap smears, etc. So those things are already out there and available. Similarly, there are automatic prescribing systems that link to a drug withdrawal, to medication prescribing and a protocol about how that occurs, which can be tailored to the patient and responsive to how the patient is going. It includes triggers for regular nurse assessment of how the patient's coping and for increasing doses and escalating care if need be. I mean, I use these regularly in my emergency department, and basically I prescribe them by clicking on a button on the computer, and it gives a tailored approach. So this technology is already out there, just not integrated into the systems. What about notification of staff for medical assistance to the duty nurse? There are technological solutions that will automatically notify a duty person, nurse, doctor, whoever, when a prison officer receives a call for medical assistance from a prisoner, when that duty officer logs it. That can be automatic by SMS, by pager. There are a number of different email, although that's slower, lots of different options. The idea is to improve communication and awareness. One of the problems in a number of these cases was the nurses denying that they knew that the person was repeatedly calling for assistance. So it reduces that deniability and improves accountability. And it also provides a more accurate record of events. Again, this technology already exists. It is relatively quick and easy to implement. Structured assessment of prisoners reporting acute health issues. Once again, there are electronic templates with mandatory fields that include what the main problem is and what the vital signs are that are already available. Vital signs, which is pulse, blood pressure, oxygen saturation, temperature, outside the normal range, automatically trigger an escalation. That escalation could be a page to the or SMS to the duty doctor. It could be an alert to call for an ambulance. Those things are already there. There are also decision trees to help with decision making. One example of that is the nurse on call algorithms in Victoria. For those of you who don't I'll give you the Victorian model. I know that there are some models in other states. But basically, in Victoria, a member of the public can ring Nurse on Call on the number shown on your screen for immediate health advice by a registered nurse. That nurse will ask you what your main problem is, and then ask you, using an algorithm, a number of targeted questions which will narrow down the likely problems with to a list of potential problems, and then give the nurse a structured advice about what they should tell the person. So should they see their GP within 12 hours? Should they take Panadol and wait? Should they go immediately to hospital? Should they call an ambulance? It's all on a structured decision tree. And there is nothing stopping the nurses in a prison using a similar system. Again, they are already available. There's also nothing stopping the nurse in a prison or facilitating the prisoner themselves participating in this sort of process. So it would be quite possible to use the algorithms or the nurse on call service for selected higher risk problems. Again, this technology already exists, but is not integrated. What about triage algorithms? Well, triage algorithms are a little bit different from the nurse on call, but have the same general principles. In fact, they've been being used since the 1990s. And their main use, particularly in the United States, has been to increase appropriate hospital referrals and decrease unnecessary use of emergency medical care. Again, they can be used by nurses, GPs, and in some cases, the patient themselves to help them decide what is the right level of healthcare response. These triage algorithms have actually had significant research studies and shown to be quite effective and safe, and to result in high levels of appropriate hospital referral. Once again, technology that already exists but is not integrated. Many systems also have built-in escalation pathways. So, for example, where I work, we have an electronic medical record. And if a clinician enters, as I said earlier, vital signs into the record or a high-risk symptom, it automatically triggers a higher level of response. So, for example, in my ED, if a person has a low blood pressure, it's automatically escalated to the most senior doctor on duty, who arranges an appropriate treatment and response. The same thing could be used, as I said, for high-risk symptoms or where a prisoner repeatedly asks for medical assistance. It's well known in the emergency department world that a person who comes back to the emergency department multiple times has a quite high risk of underdiagnosis at the first attendance. So in other words, it's reasonably likely that you've missed something, but this doesn't seem to be widely appreciated among the prison health clinicians. I'm going to spend a little bit of time talking about telehealth. Telehealth's been there for a while, but with COVID, it was absolutely transformed. It's the use of technology-based virtual platforms to deliver various aspects of healthcare. It's actually been around for decades. And in fact, in many ways, the Royal Flying Doctor Service and their pedal radios were one of the early forms of telehealth. It is widely used in Australia, particularly in rural and regional areas. Its aims are to increase access to specialist clinicians for both acute and more chronic decision-making. The structure can be doctor to doctor, talking about a patient, or doctor to patient, with the patient being the major information provider. As I said, initially by pedal radio and telephone, but increasingly video assisted. And given the ease at which webcams and mobile devices are out there, it doesn't take much in the way of equipment for this to actually be enacted. So telehealth basically supports what's called could support a facilitated virtual visit, and it can also be used for remote patient monitoring. At least here in Victoria, we're very aware that many patients with moderate COVID, so not quite sick enough to get into hospital at their first presentation, but at potential risk, were monitored at home using remote monitoring systems, which were quickly developed and reasonably cheap, that took people's pulse and their pulse oximetry to measure their blood oxygen at home, and that was linked to the hospital. It just automatically sent to the hospital, and so that they could be checked on 3, 4, 5 times a day as required, so that the care could be increased as required. So what might a facilitated virtual visit in a prison look like? Well, the patient, the prisoner, needs to be at a site where some diagnostic equipment is available. That need not be too fancy. It needs to be somewhere where there's some basic vital sign monitoring, some sort of camera, hopefully, and some sort of audio connection. The doctor is obviously at a distant site, but the doctor can talk to and see the patient. As I said, often via a mobile device. Sometimes a mobile phone is enough. In a prison, what we would call a telefacilitator, so in other words, the nurse, would help to gather objective measures using the equipment, so perhaps a digital stethoscope. Believe it or not, you can actually listen to somebody's chest at a distance using a stethoscope attached by a different person to the chest. Obviously, you can use thermometers, pulse oximeters, and these are transmitted to the doctor. The doctor then makes an assessment, a working diagnosis, and a treatment and monitoring plan, which is explained to the patient and to the nurse. Obviously, it can involve a plan for remote monitoring at defined intervals and for escalations in healthcare. So, we say, well, this all sounds very nice, but how does it happen in practice? Well, telehealth's actually really available. Currently in Australia, there are actually public and private options available. So anyone in Australia can ring My Emergency Doctor, which is shown on the screen there with the mother and child, and have a consultation with a specialist emergency physician within a few minutes, 24 hours a day. That obviously is a pay service, but it is available, and a number of small rural hospitals use it to support their junior or GP doctors in their decision-making about patients who are more sick than average. In Victoria, we actually have a virtual emergency department, which is a non-pay service, where patients, paramedics, aged care providers, and healthcare providers can be linked with an emergency physician to provide a patient assessment and advice. This technology exists and is implementable tomorrow. It just takes the will to do so. Some other examples of telehealth that are available are I'm going to use Victorian examples because they're the ones I know best, include the systems that are available in many of our smaller emergency departments, which link clinicians there with, for example, the Royal Children's Hospital Emergency Department, or the Victorian Trauma Service, or the Victorian Stroke Service. So even X-rays and CT scans can be downloaded through those systems, so that the expert is brought to the patient wherever they are. So again, the technology exists. Telehealth can also be used for outpatient review of those urgent but not life-threatening problems that we discussed. The images are obviously of a malignant melanoma and of a brain aneurysm, but they can be used for any service where a specialist review would be valuable, including diabetes, unstable asthma, for example. Another technology that could be useful to improve the accuracy of clinical assessment are so-called point-of-care tests. These are simple medical tests that can be performed at the bedside, in this case, in the prison. They're really easy to use technology, often based on a drop of blood on a cassette, a little bit like a rat test, sort of. And they can do a wide range of tests. So they can test for hemoglobin, to see if a patient's anemic. They can do basic blood chemistry testing. They can test blood glucose. They can test for cardiac damage, for example, a heart attack using cardiac enzymes. They can test for pregnancy. They can do an ECG and transmit it to a doctor for interpretation in real time. And there's a whole pile of others related around infectious diseases, including identification of hepatitis C, et cetera, et cetera. They take up only a little space and are, as I said, are really easy to use, but could really help improve the quality of clinical assessment and risk stratification of patients and who needs to go to hospital and who might not. And then the horizon coming is artificial intelligence. The diagram shows the flow of a patient through emergency healthcare. And where artificial intelligence has its main places in prisons would be in the triage decision-making and decision-making to dispatch an ambulance. But it could also have a place in the consultation phase, in particular around diagnostic accuracy. Let me tell you a bit about some of them. So in triage of patients, you may be aware that there are multiple proprietary self-sorting apps. So in other words, you use it yourself, put your symptoms in, and it tells you all of the terrible things you might have and what you should do. They are of highly variable quality, and they have a lack of validation studies. In other words, we don't know how accurately they classify people, in particular, how accurately they classify the people at highest risk. Research evidence for their efficacy is not great. And concerningly, the algorithms behind them are often not disclosed for supposed commercial in confidence reasons. But that makes it hard for clinical experts to understand the approaches being taken and the weaknesses of those approaches. Some seem to be using relatively simple probability approaches, and others are learning using AI deep learning models. But unless you know which model they're using, you cannot really understand where the weaknesses in that model might be. So more work is needed in this space and not yet ready for implementation, but probably not that far away. AI is going ahead leaps and bounds with respect to diagnosis of high-risk conditions. And these are just a few papers that have been published in recent year, looking at trying to use AI to identify which patients with abdominal pain have something serious and which don't, people who have a faint and whether it's the type of faint that's dangerous and needs more investigation or not, an acute chest pain, which is very common presentation, to try and work out which of those people are at higher risk and need a different level of care. The data is growing in this space. They are actually some of them are actually at the stage of implementation trials. So they've actually had the phase where they do repeat testing on a data set to see how accurate they are, but they're at the implementation phase of this. They're not yet widely implemented in emergency departments, but are probably not that far away. Interestingly, a colleague of mine from Brisbane is working on AI for headache diagnosis in emergency patients, particularly around which patients need a CT scan. this is really quite important because a lot of Australia, rural and regional Australia, may not have access to CT scans 24 hours a day, 7 days a week. And it may mean that patients have to travel long distances to get a scan, which may not be needed. So it's a really interesting space that's growing fast and has potential impact in prisons, because it would help clinicians, doctors and nurses decide which patients with high-risk conditions needed escalation to hospital care and which could be relatively safely managed locally. AI has been used a lot for ambulance dispatch systems. And the promise here for prisons is that it could support prison staff, not just clinicians, but prison officers, in deciding when to call an ambulance. In other words, to support common sense to get it right. There are several models in use. Some use machine learning, some use deep learning, some use neural networks. Please don't ask me to explain the difference between those. And a lot of them use automatic speech recognition that supports the call taker in data collection and targeted questioning. So, for example, a person rings the 000 number and gets a call taker, and the call taker starts by saying, you know, what's your problem? Tell me about it. And the AI system picks out the keywords in that and evaluates the way the person is speaking. In other words, do they seem to be short of breath, etc., to work out what priority they are for the potential dispatch of an ambulance. Really interesting stuff. Preliminary research has shown really good classification to the really emergent versus the non-emergent. And this is a space that could really assist prison officers deciding, well, this type of system could assist prison officers in deciding, do I need to just call an ambulance straight up? Do I need to call the nurse straight up? Do I need to call the nurse and doctor straight up? What response is appropriate? So what about implementation? Well, implementation does require a few things. The first one is that it requires a willingness to integrate technology into the solution with some infrastructure and equipment, but that's not necessarily a huge cost, given the relatively low cost of webcams, mobile devices such as laptops or mobile phones. Digital stethoscopes aren't too bad. ECG machines aren't too bad. So it's actually a relatively small investment. There needs to be a change in focus to emphasise health and response to acute health events. There clearly needs to be changes in policies and procedures, but also there needs to be collaborations between across justice in getting an integrated system, but also with external providers such as My Emergency Doctor or the virtual ED, about getting support for decision making and care. And I think the biggest area of improvement with bang for buck here is around clinical governance and getting it right. So, in conclusion, technology could address some of the issues identified in our project as being associated with potentially preventable deaths in prisoners. A lot of it is already available or could relatively easily be adapted. Point of care testing and artificial intelligence have the potential to further support prisoners and staff in decision-making regarding acute healthcare events. So technology, I think, is part of the solution.